The Week in Review, a podcast for clinicians, by clinicians, all on the path to clinical mastery and having a hell of a time along the
way. Week in Review 24, right? We got, how did you get called out in football? What was your number?
87.
Damn round! Yeah. I don't think I got hot and heavy with this. We got John in from Arkansas now, not Palmer, right? And then the crew. We're not going to introduce anybody. Everybody made it. How's your bottom side since last time?
Right.
We were kind of rough for about a week.
Yeah, you were.
I was unwell. I'll just put it like that.
Yeah, that night I was pretty.
We were about 18 hours of
not great
uneasiness.
Do we think we do it again?
I'd do it again.
Yeah.
I've been eating the sauces like all week.
Mine was, I didn't feel good for about 18 hours, and then whenever I exercised, my stomach started feeling not good.
We're just going to give you the heads up. Just go Google how much the Hot Ones kit is. Alex is just over here mowing on it for lunch.
Yeah. Well, then my patient made me the ghost pepper one to me.
Yeah. Oh, we should have tried that.
We should have, yeah.
I think like
shot next time.
A week or two ago was Johnny Cash's birthday, and I think it was just to summarize things like Ring of Fire.
Ooh.
You can probably call it that.
Yeah.
Bathroom experience.
Yeah, I ran the next day, and I had some propulsion.
Tummy trouble.
Had a couple rings of fire.
He said jetpack engaged.
Yeah.
Who's doing cases? Me, Alex.
I think I am.
Seth. Rookie's gonna lead off. Where are you in the lineup when you play baseball?
I batted first.
That's why we're doing it.
Dang right.
Get on base. Let's get it going.
All right. So I found out I was doing a case about 30 minutes ago because Daniel decided he wasn't doing his. So see how this goes. It's okay. He had a rough day. I get it.
Harry Potter and the Half Truth. Sure.
What a fantastic day.
Well,
Triple booked at 7 and made it.
and that wore you out for the rest of the day.
Triple booked at 7.
I'm just saving my energy for my children.
All right. So, man, I got something in my throat. I just ate.
He's still reeling from the spice.
Probably dairy.
Oh,
Dairy from the last one.
that's probably why yours hurt for a week. We'll be honest.
Yeah, for sure. All right. So my case, I had a 16-year-old. I guess at the time he was 15. He had a birthday in the middle of all these appointments, so he was 15 when he first came in.
That's how long our treatment plans are.
Yes, he came in. He complained of having, right-sided low back pain that he only felt whenever he was standing at work or playing basketball. He's a basketball athlete. Plays for
work.
What is he works at Publix. He just turned 16, so his hours are fixing to start getting moved. So I don't really know what he's done up until this point, but I think he's like a bagger grocery and kind of takes things out to the cars at Publix. I think that's kind of what his job is.
Mm-hmm. I'm only asking so people know because it's about 50%. Is he special needs?
No.
About half of
The jury's
people
still
at Publix, right?
Oh, yeah.
So we have to ask.
I mean, yeah.
I would say it is.
I'd say
For
for
baggers,
Mhm.
it's either young kids or it's going to lean that way. I think
And he'd
that's
be on the
policy.
other end of the 50% young kids.
But he could have been in both.
He could have been in both,
I
but
did have
he
a
was just a
cashier one
singular.
time, and she chewed out the bagger. It was unfortunately special needs, and I was just like, I don't even know what to say
Because
here.
he wasn't on his game.
No, he was moving slow.
It's Publix, man. You got
Damn, you can't drop those kind of nuggets.
yeah.
This isn't Aldi, though. Like, it's not
Aldi
you
is
feel
a
that much
speed. Yeah.
You can tell Aldi was started in Germany. They make you bring your own box, and they got I'm surprised you don't get a number on your arm when you go in there. Like, why don't you get your shit done? Yeah, it's rough, man. That's why I don't really. Great prices with customer service. Okay, back to the case.
Hey, you're good. He's still 15.
No, he's not. He's 16.
Almost 17 now. Let's see. Sorry, I gotta read my notes. He had this going on for about a year that he's noticed his low back not really too severe until as of lately. Went to an ortho, Dr. Davis.
Mm-hmm.
Went to him for his low back, who referred him here. Nothing done. He had imaging done, had an x-ray. They saw nothing on it. Like I said, he states the standing for long periods of work and also basketball are what kind of causes him pain. It's good when he first wakes up, gets slowly worse throughout the day. He's also taken some ibuprofen, but has had no change in like terms of pain, and has not used any ice or heat. He also said that he noticed his right side just feels tighter lately, and then he states kind of a little bit later, I guess, in the visit, that him and his mom have both noticed that he's having trouble kind of seeing things, like on a TV or at school. He's homeschooled, so he has like 2 days a week that he goes to I guess a school that's connected to a church.
Co-op.
Yeah, co-op. That's the word I was looking for. Yeah, so let's just take him through. I know I'm the youngest
Like
one.
that up.
I know I'm the youngest one here, I think, but I would say I'm the most mature at the moment.
Interesting. Good luck with that.
Interesting.
This is what it's like at home, ladies and gentlemen.
Him getting
Yeah.
dogged.
Has anybody seen the videos you watch on social media? I don't really know if we can make that claim.
Said they're great. Those are Listen here, you snaggletooth. Okay, so top tier cervical flexion. Let's see, he was functional.
That's
but
right. No trauma.
No trauma.
Okay.
Literally just woke up about a year ago, and he said he kind of just started noticing it then, but it never got severe enough to where he felt like he needed to get it seen. He played basketball kind of over the summer. Recently made the high school basketball team.
That's giving him a hype.
There you go.
Oh, yeah. Sorry, I thought we were like, all right, we're done.
What position is it?
That's it.
I don't know what position he plays.
You a shooter or a driver?
He's probably definitely a shooter.
Yeah.
I'm going to go based on height and weight.
McGavin.
He's probably probably stands at 3 points for sure.
Scientist.
Yeah, pretty riveting. So let's go functional non-painfuls. He was good on cervical flexion, both rotations, upper extremity pattern 1 and 2. Actually, let's just skip that. Dysfunctional non-painfuls, cervical extension, multisegmental flexion, and single leg stance on the right was dysfunctional and painful.
He has back pain when he with cervical extension.
I said dysfunctional non-painful.
Oh, sorry.
He was DN. The only thing that was painful was multisegmental extension and then single leg stance on the right. Both of those were dysfunctional and painful
For back pain.
for back pain. All right. Had him drop down, do a half kneeling inline lunge. That was functional non-painful on both of those for his, I guess, for trying
Balance,
to
yeah.
balance. Gait analysis, kind of noticed he didn't really extend through his right side of his hip, and he also had an early toe off on the right side.
Mm-hmm.
Or I guess heel lift, whatever you want to call it. Let's see, nothing positive on any orthos. I don't know if that's just me or if that's, I don't know if I just don't do orthos right, but I don't get people that have hardly anything that's positive on some orthos.
In terms of lumbar spine,
Anything.
or just overall?
Overall.
Yeah.
Like people come in and have pain like all over the place, and there's really nothing that reproduces it. They're like, no, it really ain't doing it.
I think the key word is actually.
Yeah, actually.
Actually, I don't have any.
John heard it today.
The actuallys are my favorite. I guess the only thing that was positive was stork test on the right. I'll take that one. Let's see. The other thing that's noted is...
Did you guys get caught stork at Palmer? Because we talked about this with...
No, we talked about it last time.
Yeah.
I didn't know it. I didn't know it. I still don't because I need to go back and watch the video.
The only bird we get taught is
I
pigeon.
just heard the audio.
That's a stretch.
Pigeon stretch.
Yeah.
But I don't
Or
know
birds.
if they classified it right.
Search birds.
Like for what it was for?
Yeah.
Yeah. I mean, that was a classic. I mean, here, you guys carry on. I'm going to get the ortho.
Yes, sir. He's got it. Straight leg raise is also limited bilaterally, so I'm not going to say it's positive, but it was just limited bilaterally.
Mm-hmm.
Neuro was normal. All right, so then I go through check and range of motion. Kid moves impeccable, I'll be honest. Nothing is limited, except for, I guess, if you take a straight leg raise. Palpation-wise, he had a restriction in like nutation for sacrum, and then he had right ankle dorsiflexion restriction, and then he had a trigger point in his right erector. That was kind of the big key pieces, I guess, that I found. Pain audits, I've got multisegmental extension, right single leg stance, and then functional audits is kind of those three things that I just listed: the trigger point right erector, lumbosacral nutation restriction, and then right ankle dorsiflexion restriction. Those are my 3 functional. Let's see, what did I do? Had to do some press ups because he had the nutation restriction. Had him.
My man.
Question.
Yes, sir.
But his multi-segmental flexion was dysfunctional painful?
Just dysfunctional, non-painful.
Oh, that was...
Extension was extension.
Multi-segmental extension was painful.
It was painful.
It was painful.
It was.
But he goes prone, no pain.
No pain. He can
Okay.
because he also said that I asked him what helps, and I forgot to mention that earlier in the history. I asked him what helps, and he said laying on my stomach makes my back feel better.
Love to see it.
So we love to see it. So I had him repeatedly lay on his stomach 30 times.
Repeatedly.
Um,
Little clinician overpressure? Sorry, clerk overpressure?
sorry, clerkship overpressure
Sorry,
was
Logan.
induced. He got up, stork test, and multi-segmental extension. Both of those were still causing him pain. Single leg stance on the right still caused him pain. Go back and check, and he still has a restriction, so adjusted into extension there, or I guess nutation, whatever you want to call it. Adjusted, had him stand back up again just to see, okay, is it just maybe need a little bit more, I guess, extension thrown in there. Had him go back, recheck, all of that's still painful again. After adjusting, he still has a trigger point in his right erector.
You didn't just say chronic pain.
No, I didn't.
Oh.
I didn't know. It was just chronic pain.
Throw the yellow flag in the play.
You're a 55. Sure, I don't care about that questionnaire.
And then, let's see, this is when he mentioned about the not being able to see, because I just asked him, I was like, do you wear glasses or contacts? Because he had mentioned that he had trouble like seeing in school. I can't remember how we got on that subject, I'll be 100% honest, but we got there.
He probably looked at your giant Lego rocket and was like, what the f- is that thing?
Yeah, could he even focus on the exam with that Lego rocket?
He's not facing that direction, Daniel.
In case you guys don't know, Seth is from Madison or
Athens. Yeah.
Athens,
Yeah.
around Huntsville. Huntsville, up until this year, had, or is getting taken
I
out.
saw
right?
it getting, I was driving up last night. Asheville, it was
Had a rocket from what year was that? Does that mean?
I don't know. That's not in our state. That is, I guess it's our state. That's up at the that's at the check-in, not the check-in, the rest stop.
Good God. The rest stop is part of Alabama.
Look, like I said, it is part of our state.
Anyways, he has a replica of this rocket.
It's a Saturn V at the Space and Rocket Center in Huntsville.
About 3 feet long.
Out of
Great
Legos.
googly moogly. He has a replica made of Legos in his room, and when we asked Seth why he got it, he said it was a conversation starter.
Yeah.
Has it worked?
Yeah.
I've had, let's see,
This kid couldn't see it, so
I've had a decent amount of people ask me about the rocket. I also had a girl that came in. Her dad is like really big into Legos, and we bonded over that.
I will say Legos have become more popular, which I'm not a fan of. I feel like
You said what?
they become more popular. I'm just saying I'm not a fan of it. If you want to have old nimbly bimbly fingers, not know how to chop down a tree, cool.
That's fine.
Well, go chop a tree down, come inside and work on a Lego.
That's all I'm saying. They have become more popular.
That's fine. Once I have a tree in my backyard,
What do you mean?
He couldn't see a baseball game.
it's on
TV.
the other side. If I feel like over a fence.
Yeah, get that one in the middle.
Okay,
Anyway,
back to the case.
keep going.
All right.
Studious.
You're like, what do you actually need to practice? I was like, well, I remembered it, so I'm renewing the license.
Let's see. So this is gonna be a 25-minute case on visit 1. I had him just go on his back because I just want to check his breathing. That's another part of, I guess, my exam that I do. Had him bend his knees, lay there. I can't really figure out how to diaphragmatically breathe. Worked with him a little bit. He picked that up relatively quickly. Had him progress where he picked his legs up. Kind of do some like dead bug progressions. Went back and checked all of my audits. None of them changed at all. So no, the trigger point in his right erector didn't change. The only thing I guess that changed is because I adjusted it was the
Mutation.
Ankle still hasn't changed yet either. So then I sat him back up, and at this point, I'm kind of like, all right, what am I missing? So I have my exam flow written on my whiteboard in my room. So the last thing that I haven't done yet is visual vestibular kind of testing. So I take him through cardinal signs of gaze. As I'm watching him, every time I take his left eye, I guess, to the right, so he has to converge. He has a little bit of a nystagmus there, and then when I have him converge at all, his left eye doesn't converge as well as the right side does, and then it also kind of starts trailing back towards the middle.
So just to clarify, because this is also for hopefully educational purposes. So was it during tracking that he has a blip? So that's a saccade.
Yeah.
So nystagmus is at end range with
Like if I hold it there.
So
Yeah. So
that's
if I had him hold, that's the other thing, I guess. Like
nystagmus.
he had a nystagmus when I had him go and hold at the end range. I saw the saccade, and then I held it there.
So he had a blip and
Yeah.
Okay. Cool.
So then I had him bring it, I guess, like track it in for converge. It still kind of blipped a little bit when he converged. When I hold it there, his eye starts kind of trailing out, his left eye. So I was like, okay, that's something to maybe look at. So I have him cover his right eye. I have him go and try and converge again, and his left eye has, again, no blip, no little saccade or anything. It's smooth whenever he converges there. So I had him go do some like the pencil push-ups, basically, where he has the eye convergence drills covering the right eye. Have him go through like 10 of those. Go back and check his ankle. His ankle like completely opens up. And he even mentions to me, he goes, he's like, my ankle feels completely different after that. He goes, that just feels...
And you hadn't explained anything to him?
I haven't explained anything to him at this point. I just had...
While you're doing the eye stuff. Hey.
No, I did not mention anything about his eyes being connected to his body like Alex did to his patient. If you didn't know that, that's actually a key piece, is that the eyes are connected to the body.
Yeah. Yeah.
Hopefully.
But yeah, I just told him, I was like, I'm just gonna check your eyes and stuff like that. They could have a connection, but outside of that, I'm just kind of ruling everything in and out. I again check his ankle, and he goes, that just feels like completely different. He's like, does that feel better than the left? And I was like, they're almost identical now. So at that point, I then had him flip over, checked his trigger point and his right erector. That's like completely gone as well. So since my audits are pretty much clear, I stand him back up, have him go through multi-segmental extension and stork and single leg stance. All of those, he has no pain on any of those.
And when I edit this, I'm going to throw in let the Holy Spirit come through you and he's got
Holy Ghost language. Yeah.
All right, so there we are. Visit one. Visit one.
Visit one.
That is visit one.
So, quiz time. Before we do that, we're going to take a advertisement break on stork tests. So, sensitivity is 91%, specificity 78%. I mean, that's about as high as you can get. Thessaly's is probably the only one higher than that on a standalone test. I can't believe that's not.
Another one we didn't learn either.
Which is insane.
We learned Thessaly's.
The Sally?
I didn't learn.
I learned Thessaly's.
But that's crazy. This also says it's in like a Gillet test. We got taught Gillet's test is different than that. But
Yeah, we got time.
that was an aside. Can you explain, or what is your summation of why working on convergence would change that stuff?
Let's see. Okay, I guess I forgot to mention as well, in talking to him, he said that he's noticed in basketball, he has, as I mentioned, he has pain like in his low back playing basketball, but he has a friend that he's been growing up with like his entire life. He notices that they're exactly the same speed. They both made the team at the same time, and he said that he noticed now as of recently, the other kid hasn't been strength training any more than he has. They work out together. They basically do like everything together because I think they're both homeschooled in the same program. But he said every time the kid drives to my right, he goes, I just feel like he's just blowing past me, going to the hole now. He goes, going to my left, he's not. And he goes, I don't understand because my right side's my strong side. But he just kind of mentioned that, and that's kind of one of the reasons I started diving back into looking at his eyes as well. Let's see.
Because that's what everybody's going to wonder. Like, if somebody was here and like, what's that? How in the world is that connected? How's that going down? How would you, maybe explain that to him? And then what is your like clinical explanation for that?
Yeah, so I told him, I said, whenever he's having to drive to your right side, your left eye is going to have to go to the right in order for you to be able to keep up with him. I said, if you're left,
Or you have to turn your whole body, which
Yeah.
can slow you down. Either one.
whole body has to move. So I said, one, that's going to require you to be able to focus on just the object in front of you. Two, you're going to have to use your peripheral vision. I said peripheral vision as an athlete is pretty vital for what you have to do. And I said if you're not getting a clear image of all of that together and kind of putting the pieces together with the rest of your body while you move, I said your body could throw up some little, kind of some breaks. I kind of gave him the image of what you have with your kid, where the kid was like slow as molasses, had the kid wear glasses, and then he just was like an entirely different runner. I gave him that, and he said, oh, okay, that makes sense. But I guess clinically for me, I guess that's very, I wouldn't really go too much farther beyond kind of what I said, but he also is probably going to, if he has to go to his right, he's growing. One, he's gone through like a growth spurt of like 4 or 5 inches in the last year, I believe. Two, since he moved really well.
Video coming out on growth spurts this week too. Look for that.
And two, since he moves really well, he already kind of has just, decreased proprioception because he's just growing super fast, has no idea how to use his entire body. And then if he's having to, if it's maybe his vision or something like that that's just blurry, like, again, he's just not been able to put all the pieces together. So you're kind of just having a hodgepodge of a human trying to be an athlete. And if vision is going to lead, 10 to 20% of proprioception, like, I feel like that's a pretty big piece. And especially if he moves really well, but his eyes are just like not giving him a good feedback, and it's the one thing that clears up all of his audits and the entire thing. It's like, I have to chase that pathway. I can't.
But yeah, more tension on the right side, almost like he's putting a parking brake in neurologically to just be like, hey, this is a safety play. Like, not gonna let you move into a space you can't like perception-wise or whatever you're gonna say.
Yeah, and again, like I said, that's his strong side. It's like I shoot right-handed. He's like I dribble. I learned how to dribble right-handed. So he's like, I prefer to go to my right side, as most athletes would prefer to go to a certain side, like regardless of who you are. Maybe not Dan over here. He gave me that side eye. But
he drove steps in the hallway every week.
I'm going setback 3 every time.
So then visit 2. Yes, I saw him. Oh jeez. That would be.
Was it a week later?
No, it was a few days later.
The care plan wasn't that long. Just appropriately timed.
It was 5 days later because
he is now 96.
It was 5. It was 4 days later because he actually was going out of town for his birthday. So now he is 16. So now we have moved through an entire year.
He had a quinceañera.
Yeah. He also went to a whitewater park and did some whitewater.
You go to the one in Montgomery?
Hold on.
You go to the Montgomery one?
No, he went over to Atlanta. What happened?
That's a bad joke. Knock that one out.
What happened?
We'll tell you later.
Just keep going.
He went to the one in North Carolina? South
I
Carolina?
thought it was in Atlanta. So it was like a whitewater park. I don't know.
He's making shit up.
Hey, I'm just reporting what. Don't shoot the bearer of bad news, okay? Something's funny, and I don't know what happened.
But yeah.
Keep going. Okay.
It's going to be on YouTube. Can't see
We're getting canceled for sure.
He had no pain during any of it, just a little bit of minor tightness. Said he worked a shift at Publix a couple of days ago and had no pain either. So then I take him back through all of the.
You sent him home with conversion?
I sent him home with convergence.
That's it?
I forgot. I did convergence and breathing. That's all I sent him home with.
And you told him to go to the optometrist, so.
I did tell.
Actually, I don't think you've said yet. He had not ever been.
He had not ever been to an optometrist yet.
Okay.
And his mom had mentioned the first visit that they had planned on trying to get him into one. So I kind of gave him just a couple of different names. I did Dr. Palmer, which is the behavioral optometrist down the road, because I know he's kind of on the higher end of being able to maybe get a lot of help from the kind of like vision therapy, just based on his age. But if there is other stuff that they could work on, just being how he takes in, just peripheral field. That could be another step for him. Which I even told his mom. I said, I'm not 100% sure, but it might not hurt just to see kind of like what a consult says that they could do with them. I said, one, it helps you. Two, it could help me as well, just kind of like later on down the road.
And if you don't know what behavioral optometry is and you're a listener watching, just think of an optometrist that goes beyond looking at a Snellen chart, looking at visual acuity and general function of your eyes to function of your eyes with its things that relate to movement of the body, certain reflexes that go a little bit beyond that. And then some of them, not all of them, will go into actual treatment. Some of the treatment becomes a little almost like orthotics in our realm, special glasses, charts you're working on, or it can even just be moving the focal point of glasses around to make, in this scenario, maybe the kid go into convergence a little bit to look at something up close, and then he's training his eye and then slowly move that focal point out. So that's like a functional kind of, adjunct or whatever the glasses can be, and then eventually probably get them in contacts.
Yep. Perfect.
So I got a question. So with Beau, he's probably doing this even longer than I have with like eyes and stuff. But would you have pulled the trigger in the second visit as quick as it said that, which could be a good and bad call, right? Instead of just going home and being like, hey, let's maybe do these at home, do a driver, and then...
No, I mean, we talked about this a little bit. The fact that he's having, he's just not having visual acuity. He's like, can't see a TV in class. He's out first visit. Doesn't mean I'm not treating him.
This was at the end of the first visit that I told him
suggested.
Yeah.
Like, I just think from what we heard, I mean, literally nothing changed when Seth did adjustments, range loading. He does like 10 convergence push-ups, right? And literally,
I even had him breathe as well, which we always are like, that's kind of one of our biggest audits. He's not very good at doing that. Picks it up really quickly. And then I still go back and check everything, and it doesn't change a single thing.
Yeah. But then self-reported, having trouble at school, having trouble with TV, and having trouble with sports scenarios, I would just be like, in my case at this level, I probably wouldn't see him again until I saw the optometrist, because I think it would be that big of a deal, and he'd probably, if I saw that significant of a change, just be like, I will still see you, get some visual correction first, but he may be like totally like a different guy, and then I'm like, I'm just spinning my wheels over here doing stuff that she's better at that's more suited to her. So my suggestion would be, if you're in an area and you do not have a connection to behavioral optometry, it's very common. It gets a little like, we've mentioned it to other optometrists. We work with people that teach for the school ophthalmology at UAB, and they're kind of like, that's like, in our world, I think it gets looked at like applied kinesiology or something. It makes sense to us because we're functionalists, and we're like, yeah, your eyes play with it. I think they look at it as just, we see a Snellen chart. They're looking at, basically iris diopters and how the eye functions classically, which is like going to a primary care physician. Good analogy is, our dog just had acute pancreatitis, almost died. Or Sloan takes him to the vet, and she's like, well, what sort of food should I put him on? And he gives her this like prescription of food. It's by Purina. She takes that to our, who we would say is like a functional medicine for dogs. She shows that food to her, and she goes, this is absolutely horrible. But he's saying that's research-backed food. And she goes, you should give him this. She takes that food back to the vet, and he goes, this is like voodoo. Like, this is not research-backed. I wouldn't risk this for my dog. So it's like same world. So I'm just saying, if you find that, you may find some optometrists push back. I just always say, like, this is the best optometrist in the world, which Brett said this weekend at the TMJ seminar that I went to. Don't just give a referral, give a referral with a blessing. He's like, when I give somebody over to Dr. Brimmer, who's the dentist that'll teach that, he goes, I'm just telling them, like, who's your dentist? And I'll ask them, be like, do you love him? No. If they're like kind of hem-hawing, he's like, he's the best dentist you'll ever have, you'll love him. He's like, I'm not saying he's the best at this thing. He's just like, you're going to love him. And he goes, then they're like, the confidence, that reassurance is there. And he's like, they go over there, and he goes, I don't want Darren to just make him a mouthpiece and that's all he gets. I want them to stay with him. Same thing with her, like, take your kid to him for a reason. And I do think she's awesome. So, yeah, fine.
That's the other thing is, like you said.
Cool.
Thank you. Like you said, as when you give, like, I guess, a referral, like, that's for me being a young, I guess, clerk still. I
make him wear an apron like he's in an old general store.
Yeah.
And he's selling nails and flour, sugar, like Oregon Trail.
Nails and flour. But just, like, the connections that, like...
Yes, sir.
But, like, the connections that you've made, like, in the community of, like, knowing these people, like, at some point, like, I need to also go out there and make this connection, so that way I can just like meet the person, and that way I know who I'm referring them to, instead of just being like, this is who they use, I'm gonna go refer to them. Like, then I have really no connection. I don't really know how the person is.
Yeah,
and it's like
I agree. You need to go kind of. I mean, we hung out with these people. The interesting story with Jessica Palmer, who's our optometrist we used to be, you know, if you're watching the video across the street over here, she was literally in the office on the opposite side of the building. She was Sloan's optometrist for over a year. Mm-hmm. I went into her office with her one day, and she's like, "Hey, you want a tour?" And I was like, "Sure." Just like Sloan is getting contacts, and I go by this room that had all these charts and everything, and I was like, "Is this like behavioral optometry?" She goes, "Yeah." I go, "Oh my god, like cool," because I was already doing the Z Health stuff, and she's like, "Oh, you know about this?" And we literally talked for like an hour, and I was like, and that was like 2 years into practice at this point. So just same building, right? So you got to kind of canvas the area, which I mean, if you looked on the whiteboard back here, we're about ready to redo that 10 years into practice just to, and there's new people here. We have a functional dentist up the road and all these people. So I'd highly suggest just constantly looking for people that not necessarily like confirm your biases, but are the best at what they do, regardless of what it is. So yeah, good call. Sweet. But that kid could literally be one. He may not need you. His best bet could be the optometrist, like somebody coming in and like they need functional medicine. You're like, dude, that's your functional medicine plan. Mm-hmm. It's not even a tandem. It's like that's the thing. Yeah. You know, he presented musculoskeletal, but it's not that at all.
Which is what even sent Cobb down the rabbit hole.
Seeing the things that wouldn't change, or yeah.
And I did see him. Like I have seen him 2 more times, which we have
still.
It's his ankles. I mean, his ankles crushing it now.
Which that's rare, but he's also a kid, so they're like sponges. So the adaptability is high.
And I have him still taking home just the convergence drills, and then we'll move on to somebody else here soon.
Very good.
But after the second visit, or when he came in for a second visit, his right ankle was a little bit better, but it still wasn't like up to par with like the left side. I guess if you're wanting to be quote unquote symmetrical, or it just felt limited. And I don't know how to describe the limitation that it felt, but it didn't feel joint at all. And it didn't feel like soft tissue. I don't know how to describe that.
Like neurologically imposed.
Yeah, it was just like whenever I went to go dorsiflex his foot, like even if I just like watched him, like it almost looked like he just like crunched his like core to like hold on.
Yeah, I wondered if it like you moved it there, you let your hands go to keep it there.
Yeah, well, one, he keeps it there, but he also, when I go to like push his foot up, he almost wants to like plantar flex into me. So
I think it's synonymous with, as Rich would say, leaving people playing with their derangements. If you're a McKinseyist and you just have, like, you think the in-range loading is the end-all, like, this guy would be doing convergence push-ups for the rest of his life. That's not the goal, right? Mm-hmm. It's like, well, how do you change that for the long term without just like this? Mm-hmm. I think that's the same thing. So
I basically, in this visit, I had him do sideline stuff with right eye covered.
Sideline, like DNS, like 5-month position with a cue to converge.
Because I guess I had him on his left side.
Right side, right? It's the left eye going right.
Mm-hmm.
Yeah.
And then I had him like rolling and like looking. Mm-hmm. Covered his right eye, and then I had him do the same thing. In visit, I had him take that home, and then he came back visit 3. Ankle was like almost exactly what I would expect it to feel like in terms of not restricted anymore.
Which that's coming down the pipeline more of DNS with 2 of the PhDs in Prague School looking into vision as it pertains to it. Also, that's what I've moved more towards instead of just pure eye drills is like, how do you incorporate it into like, you know, whatever it is, developmental kinesiology, bigger movements. Because obviously this guy is seeing it in basketball, so it's like you want to get him there with improvement as fast as you can. So, yeah.
And then I had the same thing in a 3rd visit in a hang stance, start loading that whole right side.
But kudos to you because you're still a clerk and you caught it, right?
We tried to.
So it's kudos. It's tough stuff.
Showing the crazy stuff we talked about.
Here, Daniel, I was into it. I mean, I'd done it all. I didn't. And then he would watch me and be like, "What the hell is that?" Mm-hmm. And then further he got it, and now he's taken more Z Health than I probably have, which is.
I've only taken 1 course. It's the essentials. It's not even the.
Yeah, you've done R and.
What? I've done R. I've done R, and then I bought the combo of S and T.
Which I just had Keith Sparks from Wichita to reach out to me. He's like, "Would you do Z Health?" I was like, "It's expensive, but I think it's worth it." Mm-hmm. Yeah. So it's good coursework. Beyond looked into it. Just an aside, a guy that was part of the FNOI, which is the Functional Neuro Orthopedic Institute, was at Winchester seminar this weekend for TMJ, and it was kind of interesting because he's like, he said, I'm big in the rehab world, like of, going to course and stuff, because I've never been to Brett's course. And he goes, I just kind of know of them. So it's funny how siloed we can be. And, I mentioned Eric Cobb, and you could tell he was like, and he was like, yeah, it's kind of surface level. I was like, yeah, I know he kind of lives in the middle, but what I kind of relayed to him, I was like, if you took a Brett Winchester and poured him with like Eric Cobb's knowledge, that's what I'm trying to do. Like, I think that's where you're just trying to like fill the gaps in as best you can. So
I just think he makes you look at audits differently.
Yeah.
Like you do an audit, you may try the same thing 5 different ways.
Yeah.
And then it's like now you've changed your audit based off one of your 5 different things you just did.
Yeah, and I would never tell anyone I'm doing functional neurology.
Right.
That's
Yeah.
I'm not.
Sure.
We refer somebody still to a functional neurologist here in Birmingham, like another network play. Like that's not my thing. I just think you can be a little bit better if you're aware of stuff. And I think that's the net we cast. Like that guy's got a shelf life with us. Like, dude, you got to go to the optometrist. You know what I mean?
And that's what I told him. I see him because I saw him again today for the third one. I told him I want to see him a week out, but I said after a week, if he comes back and like he's moving like awesome, I said like I don't want to see him again until he's at least gone and gotten either a consult with her or has seen just an optometrist like in general.
Good call. Yeah. No different than if somebody had to go to a dentist, get an appliance made, and be like, hey, let the appliance do its thing for a while, and then let's see what's going down later. Yeah.
It's also one of the things too of you're a young clerk trying to build like a practice and being like I'm not going to see somebody a whole lot of times because they probably are not in my realm. So it's kind of like a I guess being honest and not just trying to like oversell like what you can do for them, but being like, look, like did my due diligence here. This is not what you have to do. And like the mom is thankful. She's like, I'm glad you're like honest with me instead of just like come to see us low back. Because I think she's been to another chiro before and they just kind of sold like her like monthly treatment plans. And so, here we are.
One more aside, we saw a guy this morning, super guy, but he was told, what did he say? Oh, it's 30 visits of PT. He's like, yeah, it's 30. That's what we're, or whatever it was. And I was like, dude, he's looking at down the pipeline of a hip replacement is what they told him. It's not needed at all. I was like, you should know in short order if you're going that way or not based on care, not imaging. And he was like, yeah, I'm just getting worse. So like when we talk about other chiropractors and other PTs, I've gotten to the point in my career, and I told him this morning, I was like, I used to play nice, be like, oh, we'll go keep doing it. Like, he's getting worse, stop, right? You're getting nothing out of it. If you're not worse, stop. Like, there's so many other options. The tough thing for people is they don't know what's out there. Like, that's what we try to do is like, well, do we do this, right? Versus like another patient the other day, I'd been to a chiropractor, they told her, hey, in 6 visits, we'll have you there. She wasn't there. She's like, and then she comes in here, and I literally told her the same thing. I was like, I know this is what you just told me, like, give me 5 to 6 visits, and like, if we're not great, like, we should be, out of my office. So it's just, there's so much variety, but optometry, it's all the same. Dentistry, it's all the same, right? So we need a strong network, and then like give that to your patients. And that's what we're about ready to do is like prune our network by going out and marketing with people. If they kind of come back at us like, oh, this isn't what we do, like, okay. Find somebody else.
That's what I even told Dr. Davis. Like when I'm going to go see him for breaking my hand, that I
casual
using your network. Yeah.
But I looked at him and I was like, I tell people all the time, if I don't see change in 2 weeks, there's a good chance you need surgery.
Yeah.
Like because we should see change fast.
And that doesn't mean they're perfect. It just means like the trajectory.
Yeah.
Yeah. I 100% agree. What you got?
Is this going to be the podcast on high schoolers?
Who wants to do the beer run?
Oh, yeah.
Tamara? John?
Johnny boy!
Tamara!
87! Ocho siete, come on!
I'll say this about this one.
Is that good?
The first few sips, you're like, oh wow, this is good.
Give me a boot.
Once you get into it, you're like a little sweet. Like
So
I want
do we want to do a beer breakdown? So there is a gas station in Chelsea, Alabama, which is like
For
literally
all those in Chelsea.
Yeah. a minute from my house that has a liquor store attached to it that's open on Sundays. That makes me sound a real alcoholic. I know that. They have over 3,000 beers, is what the online on Google says. So I have
online Google presence.
Founders Oktoberfest. Ron's just bringing boxes.
Good man.
Nice. I like the variety. So today we have Anderson Valley, which is out of California.
This says legendary Boonville beer. So this is the Boone Amber Ale. We got a German beer, which let's see if it's actually from Germany. Nope.
California.
Grand Rapids, Michigan.
Yeah.
And then Daniel was talking about the Sweetwater out of Georgia Gummies Fruit Punch IPA.
Too sweet.
Yeah.
So I've got a question on like the regulations of everything. So
Yeah.
in Iowa, we're known for Casey's gas stations and stuff. And in
Casey's Pizza is legit.
yeah, it's awesome. Casey's, like, you can buy liquor at a gas station there, and then like other places have ABC stores. Do you guys
Yeah.
know why? Like, why is
Government.
it's called the package store here? Like, why is it called the package store?
So ABC stores are owned by the state of Alabama.
Okay.
So that's why liquor, if you go to a package store, it's like, let's say a bottle of vodka, like whatever it is, I don't know, Absolute is going to be $10 to $15 more at any other store besides ABC. That's what they get to do is preferential pricing because they get a tax break because they're
Okay.
owned by the government.
Okay.
So pink package stores, individual owned liquor stores, it's going to be always more expensive, but they're not held to the same regulations for hours. That's why this place can be open.
Gotcha.
It's just kind of weird. Yeah.
Okay.
But you cannot buy liquor in a gas station in the state of Alabama. You can buy wine or beer.
Okay.
Which is basically walk to a different door.
Yeah.
Don't ask me why I know all this.
He only had to go to 28 different gas stations in one day to find this out.
The story is I wanted a White Russian on a Sunday afternoon when my in-laws were in town, and that gas station was open, which has a liquor store and booze or beer and wine. I was like, oh wow, good to know.
So we're talking about building your referral network.
100%.
Build your referral network on all fronts.
But this guy was an expert. I asked him about Urkel, and he goes, oh, that distributor, they don't even care about us. And he goes, they stopped distributing all beers, and they own boom, 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 these beers, so don't even worry about those. And then gave me recommendations on what was similar to that. And I was like, this guy knows his stuff.
Mm,
There you go.
I'll go back.
like Seth and his vision.
100%. Yeah.
Way to bring it back.
Bring
Way
it
to
back.
bring it back.
Like riding a Segway like Paul Blart. What do you got?
I don't know if that's how. That's
What do you got, Paul?
All right. So we have a 17-year-old cross-country runner comes in with bilateral posterior thigh pain. Yeah.
Does he have a birthday?
No,
During
he's
this?
still 17. He's still 17.
It's not as good then.
Began 2 weeks ago, and he felt it after a cross-country race. It was their first race of the season. What was I? You're getting a laptop. He notices it both on easy runs and faster interval days. Quicker on a faster interval day, like 5 minutes into the run, compared to if he's running easy, it takes a little bit longer before it starts to bother him.
Is this a good athlete? Like decent runner, or what are we talking about level wise? Like what's a good?
He's got some opportunity.
He's got some opportunity, yeah, for sure.
Mr. Optimistic down here.
Yeah.
So I'm only asking because like a quick
Right.
run for somebody that's a 25-minute
Right.
5K versus like
What is
he's
he?
about a 1935.
okay, there you go. Okay, perfect.
So
I just want to know which Publix employee he was.
Wait, is he working?
no,
No.
Daniel.
I'm too busy looking at Seth's computer.
He denies any radiations of symptoms, and he's had to reduce his running volume and intensity the last week or so since it's been bothering him. He's currently been running 25 to 30 miles a week, which I guess at this point was, they come off summer training and they've been running they'd had one race. So I would assume they've started back faster workouts in the last 3 or 4 weeks.
Same amount of volume though. Yeah.
Same amount of volume, yeah. And so on exam, no DPs. Dysfunctional, non-painful, multi-segmental flexion, cervical extension, and multi-segmental rotation to the right.
Single leg stance is fine.
Single leg stance is fine. Surprisingly. Because, you look at this kid and you go, probably not super stable just overall, which is a lot of high school runners, right?
Kind of looks like Shaggy from Scooby Doo.
Yeah, a
When you
little
say
bit.
stable, are you talking physically or emotionally?
Both.
Basically.
Because you would close.
Good. So he also has a little bit of a pectus carinatum.
Yeah.
I think so.
Yeah.
Yeah. So I broke out the multi-segment rotation, and he's limited to the right in lumbar lock. So T-spine right rotation limited, which became my functional audit. Neuro was fine. No orthopedic tests were positive. The only thing that could recreate his pain was I had him laying prone, knee flexion resisted, trying to pull his heel down towards the table.
Oh, in his hamstring?
Yeah.
Both sides?
Yeah, both sides.
Yep.
Wait, say that again.
At certain
So
angles?
at
or
90 it hurt. The farther I went, the better it got.
Okay.
Which, in my head, if it was hamstring, it'd be worse the farther we went.
So what do you, like, so you're telling us what you're thinking. What do you think the other way?
Well, okay, first of all, bilateral hamstring. Like,
Right.
who
It's not your hamstrings. Yeah.
Almost somebody.
at 17 years old?
Thinking about how he stabilizes the lumbopelvic junction, like, yeah.
Yeah, but I was also very curious about the right rotation because it was very different than the left. So we went into
What was the breakup for that?
lumbar lock.
And then it was positive or
Yeah, it was limited. It was
Shoulder
limited.
and right rotation.
Limited actively, not limited passively.
So you could get him
So
in?
SMCD.
Oh, so SMCD.
Yes.
Oh, gotcha. Okay.
Yes.
It was like
Well, that changes everything.
Here we go.
It was like a third of like the left side.
Yeah.
Can you say
It was slim.
significant?
What? It was getting a little too stale in here.
Significant difference.
So
I didn't have a can to open, so I just decided to make a sound.
oh my god. So we worked on some breathing pattern, which he was pretty terrible at to begin with, which we could expect, right?
You told him that.
He's probably like 6'2", would you say? Like pretty
Oh,
tall,
yeah.
tall like a kid, 17. And so then we worked through breathing and 3 months supine, and then I put him in the right rotational plank for that rotational difference. And Tanner was in the room with me, and he rechecks right multi-segmental rotation and absolutely crushed it. Like, so much different.
It surprised me so much. I almost had to go in the other room
He had
because I was
to
about
excuse
to
himself.
laugh. Yeah, I was about to laugh at the difference. It was wild.
how many times have you seen him?
That was visit 1.
Did you test his eyes at all?
I didn't test his eyes. No.
But no, multi-segmental rotation was fine. Right was off, and that's why you broke it out.
Right multi-segmental rotation.
Well, I feel like this is just a good like teaching moment. I don't think I ever, especially if I get there passively, I'm almost always checking other things
Mm-hmm.
just to make sure. Because I feel like I don't want to false positive.
What do you mean?
Yeah.
Like I don't want to. I know I can throw them into any DNS position at any time and get it today, but I know that's not going to stick if that's not the thing. And then so
Which
it's like,
Brett also said this weekend, though, that he thinks the eyes are more of a compensatory mechanism for stuff, which I'm not agreeing or disagreeing. I'm just saying it could go either. He's saying if we didn't check his like visual acuity or vestibular, you throw him into some rotational thing, he offloads his nervous system, but then is it going to just like slam back if it was a visual acuity? Brett was saying he thinks if you're going after visual training, you're actually training the compensation, right? You're training their eyes, which is just like you're ending up in the same spot. So I think it's almost like you have to then hierarchy that somehow.
which
I don't know.
for me personally, just me and you talking this out, like I think that if I can make them do something and it's all them, and I'm not cueing them in a DNS position, and if I can make that change, it's like I know that's at least one thing. That's like they can go home and do immediately instead of me cueing them in a DNS position. That doesn't mean I'm not going to do both.
Yeah.
But
I would look at the synergistic effect. Like
Yeah.
your eyes are the driver, but they're actually not the first driver, right? The whole kinetic movement in the first like 0 to 6 weeks, like your eyes aren't the driver, but you can still start creating like, sacral stability. So then the thing becomes like, are your eyes connected from the movement or disassociated? I think that's what I'm going to start looking at more.
yeah.
So if I saw a big convergence, insufficiency asymmetrically, which is what we kind of taught, I want to see if it's tied to movement thing. If it's not, I'm not throwing it out, but I'm throwing that to an optometrist, behavioral optometrist. I'm saying,
Sure.
hey, there's a movement thing, and this, they may be connected, but I'm not seeing that in my office. Does that make sense?
I think I'm going to say that every time, too. I'm like, I'm going to throw this drill at you. This may have nothing to do with it. It may have everything to do with it.
Yeah.
And it's just like, we don't know right now. And it's like,
Worth trying, though.
Yeah.
So I guess maybe that's my limitation in the exam.
We're not saying you're wrong. We're just saying maybe because like Gray Cook would go after rolling patterns or something like this, like first thing. But the thing that he's going to cue is your eyes. He's going to be like, dude, you're looking over your shoulder. So then it's just kind of like there's a bunch of different starting points. Then it gives you different like data based on where you start too. So it's not just what you gained from the exam. It's also like, oh, you started here, so it told you something.
Yeah, it's from
It's
not
just an
having
audit. It's like audit can give you more information.
It's another spot to wave your metal detector on the beach.
Tanner's has some good analogies. That one was.
Like, you're kind of like waving like over here. You just like went right there. Good.
I think like maybe if I knew more on the Z Health realm, I like because for myself, if I would have just tested visual and I saw no lack of convergence, or that's pretty much the main thing that I look for there. If I didn't see that, I wouldn't have done anything. Whereas as we were talking about the other day, just because there's not a lack of convergence, there's other things that would be noted in a visual exam that I just have no idea about.
Right.
For me, I guess it's just because you don't see it, it's like if you don't see it, then you just move on. Like in my
100%.
opinion,
Right.
it's glaring. So it's like
gather all data.
Right.
like we always sit there and we argue at home or get mad at each other, but like we don't like.
Because you only eat rice and beef,
Well,
something's going to come to that.
yeah.
We're both on
Well,
the train, so.
Well, it's just because sometimes, like, you know, since we're still like young, figuring it out, it's like you don't see these things. When people say you see like a lack of convergence, it's like, okay, what does that actually look like? Because we test on each other, and it's like, I mean, if you like look hard enough, you might
both
like
We've
you,
both seen it.
you might could like maybe see it shift, and you're like, no, just skip on past that. It was just like. For my kid, at least, it was pretty glaring. I mean, it was almost like his eye didn't move in.
Yeah.
Yeah.
I say that over and over at the course I taught, right? Like passive range of motion, joint restriction. Like, dude, it is obvious.
Mhm.
Obvious. If it's not, you're making shit up. You're just making it up to make yourself feel like.
Yeah.
And if you're like, oh, let me go back and check it. No, you either know or you know.
Yeah.
It's not. Oh, I'm not very good at knowing. You will know. I promise you. And then you have to be confident that what you found is true. That's the kicker. Not that like, oh, I don't know. No, do you think it's true or not? And then the only way to find that out is treat.
Mm.
Go back and prove right or wrong. Right?
Well, I even think like I bet you're the same way, where it's like after you do the whole exam, the whole history, the whole everything SFMA, it's like you have a pretty good idea if I'm even gonna even check the eyes.
100%.
And then it's like, and so that if Brett was here, it's like that's what we talking to him about. It's like, well, yeah, I'm not gonna check it.
So
If all these other things aren't already there.
Yeah, it'll be very interesting when Jakob's info comes out from his dissertation and stuff. Like, it'll just be, so Keith Yoho and I were talking about this in Prague. Like, I don't think it's going to change anything because a principle of DNS has always been eyes. I mean, it comes from a neurologic standpoint. I mean, literally, I pull up those 3 slides from the early DNS A course that's talking about the visual system, how much they lean on the visual system. It's been a little bit, I don't know, subdued within there because it's become more exercise-based, movement-based. But it's like, this is all I know as a neurologist, right? Like, Pavel Kolaj came from, like, training from neurologists. Like, that's what they're looking at. And then if, like I said, you look at a baby, like, the first couple things are polykinetic movement, visual cues, and then the whole body starts following. It's like, that's all I'm looking at. And then I could really, and then you look at, like, Cobb's stuff, which I think when we say, like, oh, looking at Z Health, no, we're looking at neurology, right? He's looking at it and he's like, hey, if we're going to do some sort of visual input, where do you usually start? Supine. So you're kind of going back to almost like in a way, developmental kinesiology model, right? Go to a lower level.
So Daniel, with the SFMA and stuff, what are some like key pieces where if you see like a discrepancy in it, that kind of points you to like, hey, let me check their vision?
I mean, I feel like the easiest is single leg balance and rotation.
Yeah.
Mm-hmm.
It's like if those two are there, it's like you're gonna check a number of things. And it's like if you have passive range, then it's like, okay, why are they not getting there? They have it.
Mm-hmm.
So usually it's like, okay, what am I not finding?
Yep.
As I say, SMCD bonanza, check the visual system. So as soon as you see an SMCD, check it.
Yeah.
Like that should be your, literally, if you're a student, like see an SMCD that's that glaring, go look.
Mm-hmm.
Yeah.
Okay.
Continue.
This is 2. So he was able to run twice over the weekend, 3.5 miles. Didn't have any pain. He's going to try to run a workout that week or after I saw him second time. And then they raced the next weekend. Multi-segment road.
Is your beard red? Yeah. Holy shit.
I was a redhead when I was a kid,
Are you
Look
kidding
at
me?
he's vile.
You're a redhead?
No hair.
Well, I
Just a redhead.
was blonde when I was born.
God,
I was red.
I was his clinician. I did a terrible job. I asked that question a long time ago. Makes way more sense.
I was red for like, I don't know, a year.
I think with the
That's enough time.
the beard color though, it's copper, and I think the beard hair is like as strong as copper wire.
I think
heard
it's
that
I think
before.
it's Alabama red dirt clay.
That's Georgia.
Yeah, it could be. You just scoop some up and like
Red clay stray.
red clay strays
There you go.
Yeah.
coming to
Sorry.
Birmingham.
Proceed.
Proceed, sir. Multi-segment rotation right, functional non-painful now. We continued. We didn't change what we were doing. We were just working on the breathing, continuing to make it better. Progressed it to intra-abdominal pressure, and then we took out support from chair, bench, whatever he's doing at home. And then he was going to do that workout and then race before I saw him. Do the workout. I saw him before the race. Third visit, he's doing great. No pain in his hamstring. I'm saying hamstrings. We know it's not his hamstrings.
Mm-hmm.
And so from there, I was like, all right, we're doing good. Now let's actually like give you some things to do that are going to help you continue improving running. Right?
Mm-hmm.
Like you need to be able to control rotation to the right, or just rotation in general, as well as extension, which is what I was doing the breathing for, right? Because he multi-segmental rotation he passed, but it was like he gets to the end and he's kind of shaking.
Extension.
Yeah. And then obviously he's not great at creating pressure with.
It should be an
horsepower.
interesting one to look at. Okay, just see if he
Yeah.
flex rotation or something.
Yeah. Especially with some of the structural differences. Yeah. So that day we did a kneeling and a standing split squat, Palloff. We just did the
David
hover.
Weck would slap you upside your head.
Yeah. Oh well.
Does anybody watch his Instagram shit?
Yeah.
Oh, David Weck is on a mission for the anti-stiff core. He just thinks like that's the devil.
Oh.
And literally, just get on a David Weck kick for your Weck method. I've talked to him on the phone and stuff. He gave us his little Pulse Pros. He's a nut job. He is. He invented the Bosu ball. If you don't know,
Weck
who
is
he
Weck.
Yeah, that guy.
So it's the thing that you're supposed to like stiffen up on.
No, it's supposed to be mobile, labile to give stable.
Mobile, agile, hostile.
I'm feeling half it out.
He's an interesting guy. He'll probably somehow hear this, and I'll hear of it.
Yeah.
So
So he ran great at the race. Then I saw him for the fourth visit. I just have that he's rocking and rolling.
clinical outcome measures.
Was that your diagnosis?
We are
Diagnosis wrong.
You're out.
We were
rocking and
dead bugs today. Because I was like, look, this is literally you running, being able to differentiate limbs, creating a neutral lumbar spine with intra-abdominal pressure. You're doing the rotational stuff at home. And then, I had planned on us kind of talking about, because I don't think they get it with their program, just a general resistance training, because that's what he needs, right? He needs to be challenged outside the sagittal
I
plane.
was gonna say, do you think he needs more?
Yeah, I just think he just needs to keep doing that, right? And
But that level, or needs to keep up in the challenge?
I think he needs to up it to add weight, right? We've done some banded things,
Impact,
which is what we'll do next. But at the same time, so he's a junior in high school. This week he went on a bunch of college tours, with their school. He runs for a really small school around here, and he's running 1930. He's not.
Yeah.
He's not running college.
Yeah.
Well,
he's going to welding school.
Yeah. Well, actually, he'll probably end up being some kind of engineer, or he'll make a ton of money. But it would just, I'm assuming,
If he doesn't get caught by a bear trying to run away.
Yeah. Because most runners, even if they're not going to run in college, it's a sport that you can continue doing, right? And so I want him to, and usually that's the only thing they've done, right? They haven't played basketball or other sports or things that they're going to continue doing after. So they latch onto that and they want to just keep doing it. So
two key takeaways for me from that.
Yeah, 'cause you were there
kind
for
of
most of them.
seeing everything. I'm like, wow, you can have a huge impact if you just kind of clarify and work, with a runner that's primarily in a sagittal plane of movement, introducing other planes of movement, some cross training style stuff. You can have a great impact, and then Number 2, that's more just a comment. I think this is the most polite patient that I've ever seen.
Oh yeah.
It's
So
always
nice.
like, yes, sir, and no, sir. And he's just like, you tell me what I need to do, and I'll do it.
Mm-hmm.
That's cool.
Who's your dad's neighbor?
My dad's neighbor.
Yeah, the one who me and Beau both seen. Who saw last time.
Oh, not neighbor, but friend. Yeah.
Yeah.
Come on, Tim.
Yeah.
Ah.
He's a nice
No, they would rival. That might be him in about 40 years.
Yeah.
Tim's such a good guy.
You could literally punch him in the face with that. That was good. That was a good punch.
That was a good punch. In the flip flops.
And he used to watch his carry on constantly.
Great guy. Love you, Tim.
Oh yeah. He's seen almost everybody.
Yeah.
You see him now. Have you seen
I've
him?
seen him, yeah.
I'm about saying in set when I broke my hand. I said, let me get the X-ray and let's see him.
Yep.
All right. Bring us
Anybody,
home.
anybody got a 2x4 for Daniel to karate chop?
Yeah.
Right now? Just test the integrity of that bone.
Hey, I played softball this week.
Yeah.
He had dingers
Sore.
too.
Everything else was sore. My hand wasn't.
You didn't boot it?
I wish.
Yeah. Slow pitch bunt would be a little bit tough, huh?
We had triple.
You're like that.
I don't mind.
All right, let's bring it home. This case is about maybe the biggest fan of Week in Review, at least locally. This is a former elite gymnast, now high-level CrossFit athlete and medical resident. We'll play into some of this. Reports on July 17th with complaint of left trapezius, neck, tingling numbness. So that's the main complaint, is tingling numbness, not pain really. That just kind of spreads across the left upper trap. Works with overhead movements, in particular handstand push-ups. The amount of handstand push-ups will come out here in a minute. She's been working on an average of 80 hours a week. She's a resident. She's getting crushed. And then working out at night by herself, if that gives you an idea of what type of person you're dealing with. Yeah. No prior similar complaints. I mean, collegiate gymnast, so multiple injuries. My wife had seen her for a bunch of injuries. She was a gymnast for Alabama. No prior treatment for the complaints she's coming to me with. So that's kind of the general. General presentation, which is something that I look at more. I think I used to be just more like, let's get into SMA and stuff. Just like, how's this person like present? Like, what do they look like? What do you even call that, posture, whatever? What did she say? What was her analogy of herself? I look like a 10-year-old boy that just learned.
Oh,
Dear God, what was it?
I'm a 15-year-old boy that just learned about peanut butter.
Pretty funny. She
She's
only does
so
bench press
funny.
or something. Like, yeah, she's pretty self-deprecating, but in the best way possible. She probably listen to this, so we love it. Bilateral anterior shoulder. So I'm going to try to present if you're watching the video. Bilateral anterior shoulders, thoracic kyphosis, increased lumbar lordotic curve, and generally a little bit ramped up. Like,
Yeah, for sure.
she's built like a gymnast, right? And that's a big part of this case. So top tier, dysfunctional non-painful is bilateral upper pattern 1, multi-segmental flexion, multi-segmental extension, left rotation only, and then bilateral single leg stance and deep squat. Nothing was painful, just some dysfunctional stuff. Gait didn't really pertain to it other than her past history, which isn't. We'll talk about a little bit. Specific movement testing, 4-point rocker. If you're not familiar with that, you're in quadruped, just rocking about 4 to 5 inches forward on locked elbows. Increased T-spine kyphosis, curvature flexion. She lives there. Upper trapezius and pec major activity, and then she's an apical breather in general. Like, she's just hanging out. You can literally see her like hanging out like this and just range of motion. So prior history with her, and the biggest thing that like Sloan saw her for, and that was just I had seen her for. She had an osteotomy of her right hip, so she has pretty decent external rotation limitation in her right hip with some pain, and she's doing high-level CrossFit stuff, and she's not, limited by weight or reps or anything. To talk about the handstand push-up rep scheme that she came in, it wasn't the first visit, but second. First visit she came in, she had done some handstand push-ups, some overhead work, I think it was a snatch or something. She comes in the next time, she's like, I'm doing better, or was doing better. Then it got worse because I did 120 handstand push-ups as part of something else. Like I said, this is by herself in a gym at like 10 p.m. at night is what we were told. Maybe
She's
that
chasing
one.
demons, bro.
Yeah.
But the
she's
good
going
news
after
is
stuff.
she didn't feel it till after 100.
Yeah. It did show a good call. Did show up at 100.
Threshold.
I was like, yeah, I think I'd have pain in a lot of places. Neuro, normal. So on palpation, TL junction rotation extension restriction, and lack of posterior IAP. Like that's a big deal with her. Is like it's very hard for her to get like kind of that breath into the posterior aspect of her abdomen. Right gluteus medius trigger point, right gastroc medial trigger point, and then CT junction, left rotation extension restriction. And that plays into the orthos. So when you load in maximum foraminal compression on the left, she's like at pinpoint pain, but also some of that numbness on that first and second visit into the trap, which is a weird presentation. That's not radiculopathy. I'll give you the legit diagnosis in a sec. And then a trigger point in the left upper trapezius. And then, as I said, orthos, MFC on the left, positive with left pain. So my pain audit is maximal foraminal compression. It's literally reproduces her chief complaint. Functional audit, CT junction restriction and an upper trap trigger point. So she has a restriction and extension, left rotation on that side. Giant trigger point in that left trap. Treatment focus is T-spine extension though. She in her like that dead zone T4 to T6 is just like has a hard time conceptualizing. In this video for this podcast, I'm gonna put a video of her in quadruped trying to figure out just how to kind of get into neutral. And you're gonna see around like kind of middle trap, like where serratus anterior should kick in on the medial border of the lower scapula. You're just gonna see a big divot when we cue her up. Like she has a really hard time figuring that out. And then so treatment focus, T-spine extension with improved scapulothoracic stability. Diagnosis, I'm not going to give you an ICD-10, but like facet discogenic referral, but I would say it's more a Cloward sign, like legit disc referral. That's why it's this like specific numbness tingling. Maybe you could call it sclerotogenous, but it's numbness. It's not pain. She has a little bit of pain when we like load, which is a true what? Derangement. You have restriction pain, right? Now, that'll play into the treatment here. So first visit, we adjust all the things that I said restriction-wise, right? So what was that? TL junction, CT junction, T-spine extension, dry needle upper trap, and we actually leave her with what? Cervical flexions, which I know seems backwards, right? She needs T-spine extension, but she has that kind of upper T-spine scallop with then a like little kyphosis at CT junction, which is why she is extended or restriction extension. Extension restriction, to say it backwards. So when we flexed her, we could then load her into extension. She's like, I don't really feel anything. It's like, I even told her, I don't think it's a home run, but I think this is the best palliative thing we're going to get fast, right? Which obviously it kind of worked. So homework from that first visit was just cervical flexions, nothing else. Now in visit, we did a little bit of DNS in start position, like serratus prayer, but I didn't send her home with that. Second visit, she comes back. She's like, I'm better, but that was the visit that she's like, I did handstand push-ups. It took 100 of them to hit the symptoms. Symptoms she did say were better, and she says the referral is closer to like a local, like around CT junction, so it's not as far out in her trap. So second visit, adjust. Instead of dry needling, I just do some stecco around like cervical extensors around kind of middle lower trap and then upper trap. And then we go back to start position, and then I send her home with serratus prayer that time. Serratus prayer for her is tough. She literally, I told you, she's a little ramped up type A. So when we get her into a DNS position, she's a person that right away is just like literally like vibrating, sweating. But she's such a good athlete. She'll get it right away. It's just hard. Like, I think that's why it's hard. I think she gets into a good position fast and then like gets cooked.
And I think that's the hardest position to cue. And like I think maybe in DNS it's like the serratus prayer when it's like upper T-spine.
Which I'll give you what. So I just got back a couple weeks ago from Prague, and one of their like kind of prioritization lists for like that position or working on upper T-spine extension or axial extension was create lateral expansion of the shoulder blades first. So you're creating like basically we think of the elbows as the pumped and fixing, but it's actually shoulder blades, right? That's what's pulling the T-spine, either if it was hyperflexed into neutral or scalloped into neutral, right? It's just like you're popping a dent out of a hood like this way. Then you go after axial extension. So we cue like, hey, elongation and things. Final move would be 9 times out of 10 extension, right? So for her T4, T6 extension, or it could be flexion if somebody scalloped through the entire T-spine. Versus what we typically do is go right after extension or flexion. Like we want to approximate the shoulder blade to the rib cage one way or the other. So it's like they had a very clean, like, no, 1, 2, 3. So take that.
I've started doing that, and I feel like it's made a big difference.
Which the lateral expansion of the shoulders, that feel is tough for people to get. But when you get it, it's a key, because what are you doing? You're putting an eccentric load on the middle trap and rhomboid, which literally gives a stable point for the mid T-spine to work off of, which is why we think so many people have a problem with that. Hence the dead zone.
Do you feel like you're still getting like lat and relaxation there?
Yeah, probably more so, because a lot of people, what's their first move and start position? It's like a backward traction. So if you have lateral expansion, like literally do it yourself. So if you're at home, like put your elbows on a table, pull back towards your hip flexors, and you're going to feel your lat engage, and then think east and west or left and right, like give feedback, and you're not going to feel it at all. You're going to feel the outside of your shoulders with no lat. That is the hardest thing for people when you're working in these kind of 3-month prone start position. Quadruped is lat and pec, right? Now here's the key: there is some activity with pec, if you're in particular if you're in quadruped. You can't not hang out there with pec. It's just not dominating the movement. So we sent her home with straight prayer and just kind of said, hey, hang here. Maybe you start rocking a little bit. She comes back and she's like, it's way better, but it's still kind of there, which I'm going to be honest with you, she's probably listening to this. At that point, I was like, I think it's pretty much fine. We load her up. She can kind of feel it. She's doing great. So that's where Seth was helping me out in this visit. And we still adjusted, did stecco. Then we started doing like high bear to downward dog, then elevated high bear. So her feet were up on a step. She's doing handstand push-ups. So we got to work her into these higher level things. It was really hard for her to conceptualize uprighting in her mid T-spine when she started to go through these transitions. Really hard. So we didn't leave her with that. We just said,
The
hey,
first thing that she always did is like, you were trying to get her to like get her shoulder separate from her mid back.
Yeah.
And she always, like, as soon as you wanted to go like overhead, it was just like flex my like T-spine, and then I'll go overhead. So it was like.
But that's what gymnasts are taught.
Yeah.
And that's what we kind of talked about. Like, they are taught to fixate in flexion because you can use your rectus abdominis, but then they'll have to hyper flex their shoulders. And then what do they end up with? Shoulder pathology and lumbar spine pathology. But now we're seeing what? Compression fractures in mid T-spine, because the compressive force is being driven either from loading here or, basically rotation. And she gets all this stuff. She's medical, professional now, was a extremely high level gymnast, but it was still really hard. So she competitively, you could tell she's kind of like, and I was like, cool. But we didn't leave her with that. She went home with a high oblique sit that day, because we were like, we like what we're doing here. Let's take it down a notch. Just figure out how to load your left side with staying upright and start moving around it, and we'll move you back into quadruped from high oblique sit. So that was, first, second, third. It's literally, we've seen her 2 more times since then, and it's just been playing around with this stuff since then. Last time we went back to quadruped to downward dog, just seeing like tolerances, and that's where the video I'm going to put up is from the last visit I saw her. You're going to see when we really start getting the nuance of cues, we have her hang out for maybe 10 seconds. She fatigues out, and literally her shoulder blade just like pops off of her rib cage. So now it gets down to what? Kind of awareness, motor control, and then endurance. And then you kind of build that in. But think of 100 reps with handstand push-up. She's literally just going to do whatever she can. So she just literally, and I'm not going to tell her not to do it, just run her right over her tolerance all the time, which is going to throw her back into the old motor program, makes our job harder, but she's pretty much out of pain. So I told Seth this, or I think I did, I think she could have been done the 4th visit. I think even the 5th visit, I was like, I don't think she needs to come in, but I think she needs the reassurance of am I doing it right? All that stuff. But literally last week, she's like, I'm feeling really good. Always gonna be stuff to work on her, because she's beating the hell out of herself. She's working 80 hours a week. And any questions on that one? She's kind of an interesting one just because she's such a high level athlete. It's easy to work with, but you also it's like everybody you'd want, but then you kind of get to see if everybody did exactly what you wanted to, see it change, but then see that it's not going to be perfect still. Oh man, you can do everything I want, but then you're kind of like, yeah, it's not perfect. Keep going, keep going, keep going.
Makes me think of, again, just almost anybody who's high level, how well they can compensate. So again, it goes back to just how well their tissues are, how good their tissues are. take it where they can feel themselves really well, but then it's just like their body can compensate and tissues
Mhm.
can tolerate that. So it's like, where is the actual breakdown? Like,
Yeah.
it takes an 80-hour resident, like doc week, working out solo and 120 handstand push-ups
Yeah.
before it's kind of like, yeah, I get some like numbness down my arm. It's kind of like, that's pretty impressive.
50-year-old overweight
Yeah.
office worker. It's
He
like
goes on a walk for a mile
Yeah.
down the road,
Yeah.
and it's like, dude, I've got this back that's
or
been seeing.
paints the bathroom ceiling. Like,
Yeah.
dude, I'm dying. You know?
Yeah.
Which, like, how many Alabama gymnasts from like those championships have we seen where it's like, as soon as they get in some of these positions, I'm like, you
Most
do it
all
so
of them.
easy.
Yeah.
It's not fair.
It's not fair, but also you see how so a big point of contention in our like profession is, well, could you train an idealized position or movement? It's like, well, they definitely got trained or non-idealized, and they hang on to that for like with a death grip.
Yeah.
I mean, try getting somebody out of like lumbar lordosis, like hyperkyphosis, and then like not hyperflexing their shoulders. It's like, and that Sloan literally just hits home runs just trying to like break that pattern all the time.
Which, in like, this is one, you kind of see it here a little bit, but it's like, this is one I'll show patients all the time. So I'm like, it's like motor learning.
We'll put that. Send me the slide. We'll put it up on.
But yeah,
Put it in the show.
it's like, I always think that, like, okay, it's like, of course, if I've been doing one way, when we're talking about autonomous, like 100, 300,000 reps, and it's like, now I'm trying to learn a new way. It's
Mhm.
like, your body one time efficiently did it, but maybe in the first year of life, and then haven't done it since.
And then the thing that we talk a lot about with runners is you hit a fatigue point, so you can have great control when you have great neurocognitive function. Then you hit a literal metabolic fatigue point. It don't matter how great neurocognitive function you have, like that goes downhill. Then you gotta do two things. What kind of push that metabolic gap a little bit while you're working the neurocognitive, and I mean that's literally time and training and all this stuff. So yeah. I don't know if she's competing or anything, but I mean, it just gets down to she probably is also under an immense amount of stress by not eating awesome,
Yeah.
not sleeping awesome, and then how much of that is just driving the bus? I don't know. Probably a lot.
But again, look how far it took until something
Yeah,
finally
it's-
broke.
Yeah.
That's
Right. Yeah. So again, Winchester talked a lot about like the functional medicine side of things is just like the buffers around like when you break down and how fast you recover, which is why we should have that conversation, which she knows all this stuff. Implementation is everything, though. You can know everything and still not implement anything. But this patient may introduce herself because she might bring a case on here pretty soon.
Would love it, man.
Yeah, she's had some
She's
she's
awesome.
had some doozies so far when she's
Yeah.
bringing them up in clinic. So
I've got an ATV.
yeah, it'll probably there's a good chance. Last one was I never would have guessed it. So, any final comments? Anything from Peanut Gallery?
Nope. Just gonna.
One more. There you go. So we got some show notes stuff to put in there. Z health chart. What else we got?
the video of her.
Video for you.
Quadruped
Yeah.
Quadruped rock. Also put in stork test
Stork,
evidence.
yeah.
So you
You should also put in a picture of a belt where they're like trying to pull it together and make it snap.
So Jana from Prague was basically saying like, which everybody was like, I don't know what that analogy, like a horse tied to two posts, and if that horse tried to walk forwards or backwards, it's gonna like tighten the rope. So it's only got one option. It can move up or down, right? I've heard, Rich talk about this. Everybody explains it a different way, but like the best thing you could think of is I think of like popping a dent out of a car. You don't hit the dent, you hit beside it. Right? And if you literally hit on both sides of it, you have a higher likelihood of like popping that thing out versus hitting one side, because then it could just like deflect. That's what you're doing. You're trying to create tension on both sides of the spine, and tension being the musculature, right? Not just moving stuff around. But the biggest key there is, in particular, I think this gets missed, is it doesn't matter if you're starting from a flex position or a hyperextended position. It's moving somebody to neutral to move into axial extension. So like it's the same regardless, which makes your job easier, right? Cool. More boots, more Oktoberfests, more spin drifts, and maybe one more. We got to start doing the wild turkey on camera, though. Should have done that
Oh, we
at the
did.
start. No. You were in a different realm already. Okay. 2 weeks from
He
now.
looks like a wild.
Also, if you have a case that you want us to present, or you would like, you have questions on or something, start sending those in.
Yeah.
drbeard@gmail.com, and we can either answer questions, we can help present it, and I think we'd like to start doing that because it'll be a little more fun too.
Yeah.
So we could do like two of our own and one of somebody else's. See y'all next time.
You know.